terms, definition, concepts, and knobology with regards to mechanical ventilation. And that's me. And along with me, I bring regards from Amala Medical College, Thrissur. Now, terms, definitions, and concepts. In this, as you all know, sort of mechanical ventilation is such a big topic with so many branches. So dividing them or classifying them as per terms, definition, and concepts, I was finding it very difficult. So what I'm going to do is I'm going to give a brief overview of what I think comes under these topics. And if you hear the topic, it sounds quite boring. It sounds quite theoretical. I'll try to make it as much practical as possible. Hopefully, so you will like it then. So first of all, just a brief overview about the types of ventilators that are there. So one classification is a conventional or non-invasive ventilators, and the second one is conventional invasive ventilators, and the second one is non-invasive ventilators. So when you say invasive ventilators, the invasiveness is the endotracheal tube. So you've got a tube in the trachea, and you're supporting the breath with that. Non-invasive, you would have all seen it. The interface is probably a mask, a hood. Now, HFNO probably doesn't come as a non-invasive. It comes somewhere in between a nasal cannula and a non-invasive. Now, a different classification is negative pressure ventilators, positive pressure ventilators, and high frequency ventilators. So nowadays, it is positive pressure ventilators almost everywhere. So our talk is going to be centered around that group. But what is negative pressure ventilator? It was probably in the 1930s and 40s when plague was was rampant. Sorry, not plague. When polio was rampant, muscle paralysis. Lots of patients were paralyzed. They had respiratory muscle weakness. So they were kept in a ventilator. And actually speaking, if the mechanism of how a negative pressure ventilator works is like how your lung works. So it sort of draws in air. So the patient is kept in the tank, and then there's a negative pressure there. The chest expands, air is drawn, and that's how the patient was ventilated. Now, is it still being used? In 2018, 2 years back, I think it was an Anna or something like that. She was being ventilated. She was a post-polio patient who had later on a secondary event and then went into muscle weakness. In the night, for around 6 hours, she was in the ventilator. She was calling it the yellow tank because it was painted yellow. And in the day, I think she was using some non-invasive methods of ventilation. So yes, till recently, this has been in use. It's otherwise called the iron lung. So quiz purposes, it is called the iron lung or tank ventilator or drinker's ventilator, things like that. Now, coming on to high frequency ventilation, the main three high frequency modes were high frequency positive pressure ventilation, high frequency oscillatory ventilation, and high frequency jet ventilation. Now, the basic principle is very small tidal volumes, a very high rate. So the rate is sort of around 80 to around 200, depending on which ventilator you're using. A very small rate and a very small tidal volume and a very high rate. So again, respiratory rate and the tidal volume will give you the minute ventilation. So that is how, by the rate, that is how they were achieving the minute ventilation. Maybe around 15 years back, this was in everywhere they were talking about this. It is the best for ARDS and things like that, and all. We heard it a lot. And then things changed. Things changed as per the Cochrane review in 2016, which I think reviewed around 8 trials. There were around 1,800 patients, and then the NEJM article in 2013, somewhere around 400 patients, and they queried the role in ARDS. The main issue was Yes, for the first 24 to 48 hours, the oxygenation did improve, but it not lead on to any benefit in mortality. So was it really useful for having an extra piece of equipment in your ICU? Probably not. And HFOV, actually, I happened to work in a place which was quite close to that, and most of the papers have come from that one center in the UK, where 3 or 4 consultants were very much for it. But later on, when others started using it, they realized that probably it was not that useful. So all the papers that came saying that HFOV was great were sort of disputed. Now, is there any indication? Maybe yes. Maybe if somebody has a gross pulmonary leak where you have a high tidal volume delivered, it might just leak out through the chest tube. In those cases, maybe there is a role because it delivers only a very small tidal volume. The chances of it leaking out is less. And probably pulmonary interstitial emphysema because of the same reason, so that you don't create pneumothorax. Now, coming on to some terms that we commonly see when we have to know when we deal with mechanical ventilation. One is trigger. So what is trigger? So trigger is the signal to start an inspiration, that is to open the inspiratory valve. So the machine has to know when to open the inspiratory valve, and that is the trigger. It starts the inspiration. Limit is what happens between inspiration and the start of expiration. So basically, we'll come to these in detail in a bit. So this is basically what it limits the way gas flows into the lung during inspiration. And the next one is cycling. That is the signal to stop inspiration, that is to close the inspiratory valve and to open the expiratory valve to allow expiration. So that is cycling. So trigger starts inspiration, cycling starts expiration, and the other one is in between. Now, coming on to trigger. So suppose you have just, the patient is having just mandatory breaths. So you are setting the respiratory rate at probably 12. So 60 seconds divided by 12 is 5 seconds per breath cycle. And in that 5 seconds, if you are setting an IE ratio of 1:2, probably it's around maybe 1.6 and 3.2 inspiration expiration. So the machine is being told that every 5 seconds you have to give a breath. Okay, so the machine is the trigger. Machine does it depending upon the time. So time is being given to the machine, and the machine gives it. But what happens with that? What happens with the machine giving it? The patient might be expiring at that time, and then you know how the patient is going to feel. The patient is expiring and the machine is giving it a breath. So the patient won't like it. There will be asynchrony with the ventilator. So to make things a little bit more synchronous, to make the things a little bit more easier for the patient, came volume, flow, and pressure triggers. Okay, so these are basically the patient tells the machine that, look, I'm about to take an inspiration, give me a blast. Okay, we'll come to that in the next few slides. Later modifications were shape signal trigger, which basically looking at your flow volume loops and pressure volume loops and things like that and all, the machine decides that this patient is most likely going to take a breath now and gives it. So it was supposed to avoid wasted breath by predicting the inspiration. So from the previous, from the way the patient was breathing till then, the machine decides. So it synchronizes. But did it work well? No, it was not that good. So not seen nowadays very often. Then there came a brilliant idea. This was, I think, probably around in 2005 or something. That time, I think it was Macquet who came with the neurally adjusted ventilatory assist trigger. So what does that mean? What it means is that the patient had an EMG recorded of the diaphragm. So there was a wire put into the stomach. At the level of the diaphragm, it was recording the electrical signals, And when the diaphragm contracts, so we know that when the diaphragm contracts, it becomes flatter. That is the active process, and then it relaxes. So that active process was uh, was known to the machine, and it knew that, look, the patient diaphragm is contracting, the patient is going to take a breath, took it as inspiration and gave the breath. But again, that was practically or theoretically, it was very good, but practically again was not very useful. Basically, because what mainly happened was this the EMG recordings sort of were not great. So if the tube came off and things like that, no, they were not getting it. And this you should realize that this is forever. Once the patient is on the ventilator, every time it has to do it. So a little bit of movement or anything like that, things will go wrong. So it didn't go right. So it is not used nowadays. Good for us because things are much more simpler. Now, pressure trigger and flow trigger. These are what are there in our machines nowadays. Now, and it is quite important. So when you set a ventilator, it's better that you go onto the next screen. The first screen gives you the basics, we'll come to that. And the next screen, the top, is trigger. How is this machine going to trigger? And you will usually, what you see in our ventilators, it starts from a negative and goes to a positive. The negative is pressure and the positive is flow. So what do you mean by flow? So what happens is through the ventilator, a bias flow. That means a constant flow is going on. Okay, that is around 5 to 10 liters per minute. So that flow is going on. And then when the patient takes a breath, there is a change in the inspiratory flow and the expiratory flow. So the machine is looking at the inspiratory flow and the expiratory flow. When there is a change in the flow, that will sense it as an inspiration starting, and it will give the breath. It will help the patient. Now, an ideal flow is supposedly around 2. Now, why 2 is basically, if it's more than 2, then the patient will have, you should understand, this patient is on the ventilator, probably the muscles are not that great, and you're asking the patient to take a deep breath to take that flow in. So that might just increase the work of breathing of the patient, might tire the patient, and again won't be synchronous. The patient won't like it. So the next thing is, why not 0? The problem with 0 is if you touch the ventilator tubing, that will generate a slight change in flow, and then the machine will give it. So it shouldn't be oversensitive, and it shouldn't be undersensitive. So 2 is roughly thought as an okay value. So flow trigger is more comfortable during spontaneous breathing, and there is some evidence supporting it, though no high quality evidence, because it's not easy to say that just flow made a difference. It's not that easy, but most of the places you will see that they recommend flow over pressure. Now, when it is minus, now if at all you're using pressure, then the maximum probably I would say is -2 that you should use, because more than that, you're increasing the work of breathing. One more thing with pressure is, you should realize that suppose you're setting it at -2 centimeters of water. So till it reaches that -2, the inspiratory valve is not open. So the patient has to have a drawing in to get that -2 for the inspiratory valve to open. Whereas flow trigger, it's quite easy for the patient. There's already a flow going there. The patient just has to make an attempt, and it's much more easier. So that might be the reason why flow trigger was tolerated better by the patients. Now, limit. So limit is basically what happens between the inspiration and expiration, between the inspiratory onset and expiration. So this basically is a setting where you limit how flow should reach the patient, how much pressure should reach the patient. It doesn't mean that at the end of this volume, sorry, I think my screen has gone off. Okay, can you see it again? Can somebody unmute and tell me whether you can see it?
Yes, we can see.
Oh, yeah, okay, thank you. So when you say limit, it is how the flow is limited, how the pressure is limited, and how the volume is limited during that inspiration. That doesn't mean that at the end of pressure limit, it will cycle off to expiration. It just tells you that pressure can reach only this much, volume can reach only this much, flow can reach only this much. It will cycle off depending upon what suppose it is time cycle. So only once it reaches that time, it will cycle off to expiration, but it will limit the flow. If the flow reaches that value, it will limit it. So basically, because of this, you can set multiple limits. So during the inspiratory phase, you can set multiple limits. You can set the flow, pressure, and volume as limits and continue ventilation. Okay. So that it doesn't overdo in between. So basically, now it's cycling. So cycling is when it decides how to go into expiration. Now, inspiration is an active process. Expiration is a passive process. So the first one is time cycling. So how is time cycling decided? Suppose on your ventilator, you have set the respiratory rate and the IE ratio. So I was telling you earlier, respiratory rate of 12, each breath 5 seconds, IE ratio, suppose you have set it as 1:2, then it will be almost 1.6 seconds inspiration, 3.2 seconds expiration, totally 4.8 or 5 seconds, near 5 seconds. And the machine will automatically know that then it has to cycle to the next phase. Same thing, even if you don't have the IE ratio, suppose you set the respiratory rate as 12 and you have given the inspiratory time as 1.2 seconds, then the machine will actually give the rest as expiration, and then IE ratio is 1:2. So why it is important? In some machines, the IE ratio is not. Most of us probably know that roughly when we start on somebody, we put an IE ratio of around 1:2 because that is how we breathe. But in some cases, you shorten the IE ratio. So roughly, probably most of you would know that you shorten the IE ratio where you have problems with oxygenation. Okay, you want more time in inspiration, and one of the examples is probably ARDS, a stiff lung. The cases where you prolong the expiration is where you don't want autopy. So when there is some bronchospasm like asthma and things like that, now you want to, the oxygenation is not an issue. Carbon dioxide, getting the carbon dioxide off is the issue. In those cases, you want a prolonged IE ratio. Okay, so the one thing to note is there are machines where they don't allow you to enter the IE ratio, but instead of that is the inspiratory time. So you would have set the machine, and the patient might be breathing very fast, and then what will happen is the IE ratio just gets changed. So you might want the patient to have an IE ratio of 1:2, but it might not be that is happening. So what you should do is you should look into your inspiratory time, and below that the IE ratio would be calculated and it will be written there. Only thing is that you have to look at it. Okay, so if the rate is very high, you might have to adjust the inspiratory time. I hope you got it. The next is volume cycling. So volume cycling is like your mandatory VCV mode. Your VCV mode, volume control mode, inspiration stops once the set volume is achieved. Once the set volume is achieved and the respiratory rate is taken. Like you look at both of these and it stops after that. Pressure cycling is mainly for alarms. So basically, because now you might be thinking about pressure control ventilation, but pressure control ventilation, the ventilator doesn't cycle into the expiration phase as soon as it reaches the pressure. It cycles only as per the time. So what is pressure cycling? Pressure cycling is, suppose you have set a pressure limit, P max. Usually you set the P max at around 40. So you have put the patient on volume controlled ventilation. You've set an alarm at 40, and then you're giving a breath. Once the breath is being given, if the resistance is so high, like it's a tight lung, then it will touch the pressure limit and it will cycle off to expiration. So pressure cycling is mainly for the alarm bit. Flow cycling is for spontaneous modes. So it's for the patient to know that when I have to cycle to expiration. So, and historically, 25% of the peak inspiratory flow. So initially, how you breathe is during inspiration, there is a peak inspiratory flow, and then you slow down. Okay, and when it reaches around 25%, the machine takes that as an expiratory phase, and then it does things accordingly. Now, the next thing is Knobology. So now, the part of the topic, the terms, concepts, and things like that, a few things will come in this as well. I've just sort of made it together. So this is one of the ventilators that we have in our ICUs, Dept.of. So I just took a screenshot of the first screen. Now, yours might not be the same, but most of the parameters might be one of these. Okay, the main ones will definitely be there. The second screen and the third screen might be slightly different depending upon which company ventilator you use. So the first thing that you usually set is FiO2. Now, if somebody is quite hypoxic, I won't hesitate starting the patient on FiO2 of 1 or 100%. Because in my textbook, oxygen is one thing that has to be de-escalated. It is not sort of an escalating. You don't want to put the patient on a little bit of oxygen, see how it is, then increase it, then increase it. You give a good percentage of oxygen, then come down. You don't have to wait for that long because you have a good monitor like pulse oximeter there. So you don't have to wait for that long to come to a reasonable. It need not be the exactly right FiO2, but a reasonable FiO2. Now, so how much to set is depending upon how your patient is. What you are looking at is probably a recent SpO2. Now, what is your recent SpO2? So what is your decent SpO2? Mine will be maybe somewhere around 94% plus, or if it's a COPD patient, maybe slightly lower. As pulmonologists, you guys might know what this patient normally runs on. It might be there in this chart. So depending upon that, you can set the FiO2 and look at the pulse oximeter. Now, the next thing is FiO2 and PaO2. Okay, we'll come to that. The next thing that you usually set is the tidal volume. Now, the issue with tidal volume is you don't want to give too much of tidal volume because of barotrauma, wally trauma, and things like that. So the recommended tidal volume is around sort of 6 to 8 ml per kilo. And then see how things are. So what I tend to do is once I have the initial setting, after around apparently it takes around 20 minutes for your settings to reach the blood gas. So after around half an hour or 45 minutes, I ask them to take a blood gas and then I tweak things. So initially I might be a little bit sort of elaborate. It's like how you give a broad spectrum antibiotic and then depending upon the culture, you become narrow spectrum. So like that. So be a little bit broad spectrum when you start off, do a blood gas in probably half an hour, 45 minutes, and then become narrow spectrum. Great. Now, we all know the respiratory rate 12 to 16 per minute. If you ask me, most of the patients that we have to put on the ventilator, the majority of them will be metabolically acidotic. Okay, they'll be sick because of either sepsis or diabetic ketoacidosis or something, or renal problems. Or it is usually a metabolically alkalotic patients that you put on the ventilator. So because of that, what I tend to do is I always tend to put them on a high rate at the start, because what I don't want is a pH of 7.1 and then this patient was having a respiratory rate of 35. That is why I put him on the ventilator, and then he was actually compensating for himself by increasing the respiratory rate. And then now I put him on the ventilator, I've put him on a normal respiratory rate, and what happens is minute volume comes down or minute ventilation comes down, and then the next blood gas is less than 7, his enzymes stop working. I've started that vicious cycle of each organ failing. Okay, so what I would suggest is always put them on a high rate, do the blood gas after a certain time, and then get back to how things, and get back to adjusting things. Okay. IE ratio, as I told you a bit about it, like normally 1:2, so it is T inspiration, time in inspiration, or IE ratio, whichever your ventilator tells you to do. 1:2 normally, depending upon the patient. If the patient has a bronchospastic element, prolong the expiration. If not, when you say prolong the expiration, what you're looking at? You're looking at your flow volume or your pressure volume loops, and you're trying to see whether the expiration, whether the next inspiration is coming before the patient has fully expired. So before the pressure comes down to the peak that you have set, if the next inspiration is happening, then there is always a chance that there might be an auto peak that's going to happen, and which is going to be detrimental. So look into that. If you think that there is bronchospasm, how will you know that there is bronchospasm? One is ventilator pressures will be very high. The second thing is that when you clinically auscultated the patient, there'll be wheeze. So in those sort of patients, be a little bit careful. Look at the loop before you set the IE ratio. And where you prolong the inspiratory time is when you need oxygenation, when you need more oxygen. You are on a high FiO2, things are not doing that great, patient is probably having ARDS, then you probably, you sort of alter the IE ratio. Books say maybe 2:1, up to 2:1. The problem you will have with 2:1 is expiration will be a problem, carbon dioxide elimination will be a problem, but then allowing a little bit of hypercapnia, as long as the pH is decent. Like when I say decent, I believe in a pH of more than 7.2. Some people say 7.1. As long as it's like that, probably I can alter the IE ratio a little bit in those cases. Next is PEEP. Does every patient who's going to be on a tube, or does every patient who's intubated, do they need a PEEP? Why should I think like that? The reason why I'm thinking like that is your vocal cords are maximally apart when you inspire and are partially closed when you expire. So that partial closure, theoretically, it probably produces a PEEP. But again, practically, they've tried to assess all the volumes and things like that and they haven't really found evidence behind it. But theoretically, once you put the tube between the vocal cords, you have taken that effect of partial closure. So I am actually a fan of PEEP, I should say that. At least a PEEP of around sort of 3 to 5 is what every patient, I think, should have. Do I have any evidence for that? When I was a postgraduate, we never had, we were the ventilators. Okay, so inside the operation theater, we were the ventilators. So when you are using the bag, you don't apply a PEEP. So once in a while, if it's a very long case, what we used to do is we used to have a PEEP valve connected to the anesthesia machine, and like that, a fixed PEEP of 5 or something like that, and then we used to give PEEP. But that was very rarely, because that was another piece of equipment that you had to open for each patient. Nowadays, our ICU ventilator, theater ventilators, everything has a PEEP facility, and there are lots of studies which show that the patient's oxygenation has been better when a little bit of PEEP was given in drop. So all my patients nowadays, if they have a tube in, they will have a PEEP. And the PEEP that I usually set is around around 3 to 5. The next concern probably somebody is probably thinking of is what about PEEP and blood pressure? Because that is what I have been asked often. When I ask them to increase the PEEP from 5 to 7, immediately the nurses will tell me, sir, the patient is on NORAD. Okay. They've looked into this part and they've found that till around a sort of PEEP of, they say up to 15, or like it's only beyond 15 to 20 that PEEP apparently affects the blood pressure. How does it affect the blood pressure? We all can probably derive that from our physiology. Increased intrathoracic pressure, decreased preload, and the BP should fall. But again, and especially they say that if it's an ARDS lung, okay, the patients in whom you need a high PEEP is somebody who has a stiff lung. So when it's a stiff lung, the increasing PEEP does not actually alter the the outer pressure of the lung. So basically, because it stays internally, so because of that, it doesn't affect the blood pressure. So if it's a normal patient, if the patient's lung compliance is normal, then probably if you raise the PEEP too much, it might affect the blood pressure. But in a patient who has a tight chest, it doesn't matter. So yeah, And now I'll probably weigh the risk versus benefit. A little bit of blood pressure fall, if it's a little bit, I can supplement it with something, but I need oxygenation to happen, and PEEP is a good way of doing that. So it will be probably a risk versus benefit. Now, why am I making things a little bit complicated? The reason is, one of the things that we all forget is, on our blood gas. So I tend to ask this question to the house surgeons and the PGs and junior PGs especially, about the patient will be in the theater probably on a 40-50% oxygen. I'll get a blood gas, and the PO2 will be somewhere around 110, 120 or something like that, if it is. And I'll show them, and I'll ask them to comment. And they always will say that, oh, the PO2 is great. It's actually supranormal, because on your blood gas, there is a range written 80 to 100. Okay. Or 60 to 100, whatever it is there on your blood gas. Now, that 80 to 100 is basically for somebody who's breathing atmospheric air. So if it's 21%, then 80 is fine. But as the FiO2 goes up, your PaO2 should go up. So that is how you should calculate. So you basically should calculate and tell them that, look, this patient is hypoxic because of what we are going to discuss now. So how do you calculate the amount of oxygen that the patient is being given? So that is the PaO2, P capital AO2, that is the P alveolar O2. So the P alveolar O2 can be calculated from this equation. And what is there in this equation? Suppose the patient is breathing at room air. Look at the second part of the equation. The FiO2 is the amount of FiO2 oxygen that you're giving, the percentage concentration of oxygen that is there in the gas that is being delivered. Atmospheric pressure is Pb, and water vapor pressure is saturated water vapor pressure is pH2. So atmospheric pressure 176 or something like that. The other one is around 45. And if you calculate that, it will be around the whole thing, PaO2. Normally, if somebody is breathing room air, should be around 99.6 or something like that. Then you are looking at the so this is the capital A. In that AADO2 ratio, this A is that capital A. The small a is got from your blood gas. So that is the PaO2. So that is the small a. This difference is what you're looking at. And the normal difference is, there's a calculation like h by 4 plus 4, but roughly it goes from around 5 to 15. Okay, it depends upon the age and things like that, and all the changes. So if it is very, very high, if it is more than that, then this patient is hypoxic. Now, I did complicate things a little bit. At your level, I think it's pulmonology, anesthesia, and guys like that and this. So at your level, probably you should know this. To the house surgeons, what I tell is there's something called a 5-4-2-1 rule. So if somebody is on 20% oxygen, and if the PaO2 is 100, 5 times PaO2, that's a supranormal lungs, excellent lung. If it is 4, still a very good lung. 3, okay, I'm fine, I'm happy with it. 2, I'm worried. 1, I'm really worried. Okay, 2 and 1 is probably ARDS sort of picture, where the PaO2 FiO2 ratio is more than it's less than 200 and things like that and all. But roughly, you can actually calculate it by the 5-4-2-1 rule. Now, continuing with the Knobology, I've gone into the next screen. So in the first one, you can see inside, you can see a ventilator setup, SIMV, VC, and the next screen. Don't worry, you cannot make out what is written in that. I've written it down separately. So I've just taken that part, and this is what's there in that. Now, this is for this ventilator, but more or less the things are the same in different ventilators. Some of them might not have all, some of them might have a few, 1 or 2 extra things, but the main things are there. Now, we discussed in detail about the trigger part. Okay, so minus to plus, minus is pressure, plus is flow, and what I would recommend is a plus of 2. If you think that the patient is still struggling, we had a patient, when was it? Probably around 3-4 months back. Even with 2, the patient was struggling. he was not able to sort of tell the ventilator that he was getting a breath. So all the breaths were machine driven, and you could see him making attempts, but the machine was not giving that pressure support ventilation. Okay, so that is why you should actually look at the patient as well. Each time you set it, you should look at the patient. You can look at the oxygenation, you can look at the carbon dioxide, we all do that. But along with that, look at whether the patient is synchronizing with the ventilator. Okay, so sit there for some time, do some adjustments. Nothing grossly is going to happen by doing fine adjustments, and see how things are. Play with these knobs. Okay, yeah, and then what we did is reduced from +2, we reduced it to +1, and then with that flow he was fine. Okay, now so coming on to the next bit, what is trigger window? This is probably not that important, but again, I've just since it's there on that screen, that's why. It is the percentage of the expiratory pause that the ventilator waits for the patient's effort. Not that important. This expiratory part is not that important. Inspiratory pause is important, but not that much of trigger of expiratory pause. So because of that, the trigger window at. Okay. Now, bias flow, I mentioned about that a little bit earlier. Bias flow is basically if somebody is, there is a constant flow through the ventilator going at around 5 to 10 liters per minute. Most of the ventilators is in that range, some ventilators a little bit more higher. And it is a drop of that flow that the ventilator senses and then gives the pressure support. The ventilator senses and knows that the patient is going to have an inspiration and does something for it. So that's bias flow. The next is inspiratory pause. That is a little bit important because the concept actually involves including a period during inspiration when there is no flow. So you have given whatever you wanted to give at the initial part of the inspiration, and then it's kept like that till expiration happens. The expiration is going to happen depending upon how your cycling was. So if it is time, it is flow, it is pressure, whatever it is, depending upon that is going to cycle, but then you do till that time it is maintained. And this is like you holding a breath. Okay, do patients like it? Yes, patients do like having an inspiratory pause because that's how more or less how you breathe when you have a problem. So that sudden big take and holding it for some time is what the patient needs at that time. And the advantages are supposedly in the carbon dioxide elimination, which is again another big function of the lung, and it is due to dead space adjustments. The usual setting, they say, should be at around 20%. So that's where you should normally set it at. I told you about the inspiratory pause. I told you that how we want the breath to be delivered is quickly and fast at the start, and that is the inspiratory rise time. Okay, it is rise time or inspiratory rise time, and it will be as per if you set a pressure as in pressure control modes, it will be based on a flow if it's a volume control mode. Okay, and the default is 5%. If it is in seconds, around 0.15 seconds. So that is the default, that how you set it, and then you look into it. Now, what is the problem? If you deliver it very fast, if it's a very tight lung, then what might happen is it might just cycle. It might touch the pressure limit and might cycle off. So you should look at whether you can do something to the inspiratory rise time. Can you reduce that a little bit so that the patient will get a little bit more sort of time in inspiration, and whether that will help. So if it is too fast, that is the problem. If it is too slow, what you should realize is just think about inspiration is an active phase, and expiration is a passive phase. So during inspiration, what happens is, suppose it is very slow. So the air will go into the lung and then it will dissipate, and then the pressure is quite low. So during expiration, not that much will come out because the air, probably part of it is in the distal alveoli, and it probably doesn't have time to reach the ventilator back during that time. So that is the problem in having it very slow. Plus there won't be that much of air going in during inspiration. So because of that, having it very slow is really detrimental. Having it very fast, usually you will know about it. So if you think that it is hitting the pressure limit very quickly, try to slow things. Try to look into the inspirator rise time. Try to slow it and try and see whether things are okay. But always looking at whether a decent tidal volume is reaching the patient. Now, if I continue with the Knobology, that is the next screen after that, it comes the end flow. So the end flow is basically to determine the time of cycling to expiration. So we told about that a little bit. Historically, it was 25% of the peak inspiratory flow. When it comes to that, on a spontaneous mode, the machine knows that, okay, the patient is probably now going into expiration, and allow him to do so. Okay. Pressure limit, it is the pressure set above the PEEP to which you allow the lungs to expand to, okay, in the pressure control mode. You would have seen these typical flow patterns. The probably interesting ones nowadays are maybe the decelerating and the sine wave. Okay, the decelerating ones are in the pressure control mode. I told you, suppose you are putting somebody on the pressure control mode, it will deliver initially quickly, and then it will hold on, and then it will go into the expiration. So that is like, it's like a decelerating wave pattern that happens. On your volume control mode, also you can give it like that. If by doing so, if the pressure is not going too high, then probably that is a better way of doing it. Okay, but if the pressure is going high, then you might have to adjust it accordingly. Accelerating mode, don't look at it because it's not recommended at all nowadays. It's quite a few ventilators. I think it's the Macquet which has a sine wave, and that is probably as good as a decelerator. I couldn't find one better than the other. I couldn't find any evidence for that. Other things, now in some other ventilators, I think it's the Macquet, there is something called an inspiratory cycle off. When should the inspiration be off? And the default is set at around, it has a range of 0 to 70%. The default is supposed to be 50%. There is something called augmented tube compensation. So what is that? Now, I know that there are going to be quite a lot of talks after this, there are quite a few, and somebody is going to deal with weaning. One of the things with, I'm just because it comes under that Knobology, that's why I'm discussing about that a little bit. When you put somebody on an endotracheal tube, and before extubation, suppose you put somebody on a T-piece. Suppose you put somebody on a T-piece, it is like breathing through a straw. So it is not that easy to breathe through a straw. So if you prolong somebody on a T-piece, then what is going to happen is slowly there will be basal atelectasis, because what is going to happen is he's keeping on breathing and the distal alveoli will start closing, and that can lead on to basal atelectasis. That can, other things is it can probably impede the carbon dioxide going out, because oxygenation doesn't need that much of air to come in, but carbon dioxide definitely needs a little bit of air to go out. So yes, so these things might get affected. So one school of thought is put somebody on a minimal pressure control, so minimal pressure support of 5 to 6 before you think of extubation. So if somebody is on a weaning mode, you put them on a little bit of pressure support just for the tube compensation, and then take the tube off, if he's doing well on that. Okay. Now, two things. One thing is, if you take the tube off, this patient might have been in the tube for some time, for a few days, and there might be some edema, okay, around the vocal cord. So somebody on pressure support for a long time and then taking tube off apparently does not guarantee, and in my opinion as well, does not guarantee that the patient will breathe like how he was breathing with the tube, because the tube, the vocal cord, our vocal cord space is not going to be that great. Okay, so what you can do is, you can always do a spontaneous breathing trial, but restrict that T-piece trial to around sort of 20 minutes. So 20 minutes, if he's fine without any support, then you can probably think of taking it off. What augmented tube compensation? If you put that ATC on in the ventilators which have it, what it does is it supports that small breath. It is like a small pressure support being given. They haven't told us how much is that support that they're giving, but it is like a little bit of pressure support. Okay, so that is just to know what is that ATC. So summary is our aim by ventilating somebody or using the ventilator in the ICU should be adequate oxygenation, achieving adequate oxygenation, achieving adequate ventilation, but at the same time, what we always tend to forget is achieve patient friendliness with the ventilator. Make the ventilator his friend. Okay, so synchronous, make the ventilator sync with the patient. And for that, it's good to know a little bit about the knobology, to play with these knobs a little bit while you're in the with the patient and see how things pan out. Okay, thank you very much.
Thank you, Joe. Can you hear me?
Yes, I can.
Yeah, Joe, it was an excellent talk on the basics. Actually, you have made the foundation of critical care today, and the topics will be carried forward. I think, Ami, you can put the unmute the participants so that if there are any questions, they can ask freely to Dr. Joe. Amy, can you hear me?
So I can hear you. The
Yeah.
participants need to unmute themselves
Unmute, yeah.
because I have not muted them. They have muted themselves. So
Okay.
they can just click on unmute and they can ask questions, or they can raise their hand and I can redirect the question.
Okay.
I would request the participants, if they have any question, please ask them, or you can put it on the chat. So we have a question from Dr. Anjali, from Dr. Anjali. Sir, can you elaborate about NAVA, NAVA?
Okay. So now I can't see you because my screen is blank now. I hope you can.
So you can just stop sharing your screen. Just click on stop sharing, the same button.
Same button, is it? Okay.
Share. No.
Okay. Now it's fine.
Yes.
Now it's okay.
Yeah. So basically, NAVA, that's what they did is, I think it was Macquet. They were trying to make the patient synchronize with the ventilator quite well. So their idea was to try and figure out the diaphragmatic contraction. So when is the diaphragm going to contract? If the machine knows that, then that is probably the start of early inspiration, and the machine could give it at the same time. So it was like something like a wire or an NG tube put through the nose into the stomach. At the level of the diaphragm, quite a bit of it was a sensor, and that would sense the mechanical. It's like an EMG. It would sense the mechanical activity of the diaphragm, and as soon as the diaphragm contracts, it will sense it as an inspiration, and the machine will support. Okay, but the problem, as I was telling, what happened was uh, this is something that every breath has to be supported. The machine should know and has to be supported. So if it's misplaced a little bit, then that will obviously lead to the machine not helping out. Okay, so that's what happened. It didn't support it that well, and because of that, it was not taken by other companies, and nowadays I don't think it's used anywhere. Even Macquet, I have a doubt whether they have it in their recent ventilators. And one more thing, when you think about it, it is another thing that you have to do. Apart from ventilation, you have to put this tube in, you have to readjust it accordingly. So it is another cumbersome thing. So that might have been the issue. I hope you got it.
Yeah. Can you hear me?
Yeah, I can.
Yeah, Dr. Anjali, actually we do have a 1 hour talk on NAVA by Dr. Ajit from Bangalore. Maybe in the after 3-4 months. Dr. Joe, you can
Yeah.
hear me, right? Yeah.
Yeah, yeah.
Can you elaborate on the knob inspiratory pause in a case of ARDS? How the usefulness of inspirator checking for inspiratory pause and getting the plateau pressures in ARDS? Can you just explain it?
So basically, conventionally, what we want is we want the inspiration to happen quickly. Because that's how we breathe. When we breathe, when we inspire, we take in a peak inspiratory flow, and then things slow down, and then we go into expiration. So that's how we normally want. Suppose it's an ARDS patient, and suppose you put the patient on the ventilator, and it is as soon as you start the ventilation, suppose it is hitting the pressure limit. So you would have set a pressure limit of, usually we put it at around 40 p max. When it reaches that, it will cycle off. So it's not helping the patient. So in those cases, if you go onto the inspiratory pause and see whether you can sort of prolong it a little bit. Two things. One, you should delay the inspiratory rise time, and adjust the pause accordingly so that the flow is delivered over a slightly longer period. Now, the problem with that, if you prolong the flow for a slightly long period, what is going to happen is, in inspiration, that much of flow is not going to happen. So one of the things that helps oxygenation is actually in inspiration, holding the breath for a longer time. So that won't happen. So it is actually a play. So at the same time as not making the patient go into expiration, you probably will have to adjust the inspiratory time and see. You'll have to play with these knobs for some time. One more thing is, since Dr. Rennis, he was asking about ARDS in specific, two places. Now, one is ARDS and one is asthma. So in ARDS, you have every chance that the patient might have a pneumothorax. If you increase the pressures, that is your worry. So in ARDS, what we tend to do is, rather than the P peak, we are worried about the P plateau. Okay, so even if the P peak is slightly higher, as long as the P plateau is less than, maybe I'll say maybe around 30, I would still go on, because I have to have this patient survive somehow. Whereas in asthma, what happens is, because there is a bronchospasm, as soon as you hit the pressures, the ventilator will cycle. So what happens sometimes, quite often what happens, or if you call me, if you ask me to intubate an asthmatic, that is my biggest worry. Because if I put a tube in, as soon as I put in tube in, the patient will be having a reactive airway, the patient will go into bronchospasm. Every breath the patient will just won't allow to take, and then the ventilator will just keep on alarming. So what you should think in an asthma is, where is the pressure in an asthma? The pressure is generated in the bronchioles and not the alveoli. And the bronchioles have a muscle in it. So because the bronchioles have a muscle in it, it is unlikely that that will break and cause a pneumothorax. So if it's an asthmatic that you're having a problem with, I will increase my P max to maybe 40 or 50 or whatever, 50 or 60 or whatever it is, because unlikely that you will have a pneumothorax. Okay, so yeah, this is just something because of its ARDS. This is how I'll play with the inspiratory rise time, inspiratory pause, and this part to ventilate the an asthma.
Excellent. Thank you.
Okay, do we have any more questions? So Dr. Mohammed Kuti is asking, sir, what is the ideal PEEP to start with?
Yeah, again, I was telling about that. My ideal PEEP will be around, in the ICU, it will be around 5. Okay, and then I'll think about it. So where do I think about it? If the patient's oxygenation is an issue, then I will, again, somebody is going to talk about PEEP. So I think there is one full topic on PEEP. So there is something called, we know that there's a pressure volume loop, and there is a PV tool in that. So if you, every ventilator, most of the ventilators have something called a PV tool. So I'm sure that the person who's going to talk on PEEP will tell you how to look into the PV tool to roughly tell you where your PEEP should be. Okay, now, when I tell about that, this PV tool that I think came around 20 years back, it was considered a great thing. So what we used to do is, we used to paralyze the patient. Even if the patient is breathing, we'll paralyze the patient, and then we use the PV tool to find out the upper deflection point, and when the lower deflection point, and where the lower deflection point, we'll get the PEEP to near that lower deflection point. But what happens in reality is, after that muscle relaxant is worn off, the patient will be starting to breathe spontaneously. So then the PEEP goes all over the place, because till then the patient was static and now it is a dynamic thing. So this PV loop, actually looking into that and doing it, was very, theoretically was great, but again practically didn't work very well. So currently what people do is as per experience. So we'll start off with a PEEP of 5. If somebody is definitely going to need a lot of oxygen, I'll start off with a higher PEEP. And when if it's the ARDS patient, I'm not bothered about the blood pressure at all. So it might be 8 or 10. And then I'll look at the blood gas after half an hour, 45 minutes, and then decide upon things. So 5 will be my minimum. Now, when I say 5 will be my minimum, the one place where I'll be worried will be an asthmatic, because of the problem of auto PEEP. Okay, so what is auto PEEP is, before expiration, the next inspiration sets in. So if you look at the pressure volume loop, you will see that it's not coming to the baseline. With the baseline or 0, or if there's a PEEP to 5 or something like that, it's not coming to that, and before that, the next cycle is coming. So in those cases, what one school of thought is putting off the PEEP. But apparently, putting off the PEEP doesn't work, because putting off the PEEP is actually negates the whole issue. So they say that even if there is auto PEEP, a little bit, 2 or 3, maybe a small extrinsic PEEP does help in keeping the alveoli open and actually decreasing the auto PEEP. Okay, I'm sure that the person that day will tell you, because this needs a little bit more. So I'm sure that person, or if not, you can probably ask him. What are the things with auto PEEP and putting a little bit of extrinsic PEEP? Okay, yeah. I hope, Dr. Mohammed, I hope you're clear.
Okay, any last question, or we can close the session? Okay, so we don't have any more questions. Maybe we can just close the session.
Thank you all.
Thank you, Joe, sir, and thank you, Renissa.
Yeah, once more, Dr. Joe, that was an excellent overview of the basics, concepts, and the terminologies, and the knobology of the ventilators. I think that was an initial, good start for the program. Next week, we will have Dr. Rajesh from Rajagiri with us, who is an expert pulmonologist, who will be delivering talk on the indications of mechanical ventilation. Once again, thanking you, Dr. Joe, for taking up the time and the space for us to educate our residents as well as all the faculties over here. Thank you, Joe, and see you soon. Thank you.
Thank you for the opportunity. Thank you.
Renis, sir, I would request you to stay back for a minute. I would request all the others to exit the group so that we can close the session.
Yeah, I am here only. We all
Okay.
three
So just
moderators
hold
are
on
here.
for a minute.
Yeah.
After everyone's left, I would like to speak to you
Sure.
regarding the brochure. Yeah.
Sure.
Sir, I think everyone has left now. I have also removed people who were there. So
Yeah.
only two things. One was I think Sudhir sir must have sent you an image with where I have marked the boxes.
Pardon? It was not clear. Ami, can you explain once more?
Uh, so just hold on. You hold on. Can you hear me now better?
Yes, I am. We are holding on.
Okay. So what I was saying is there were 5 doctors whose we have not received the
Yeah.
credentials.
Okay.
Yeah. So
I,
Dr.
I think,
Anand, Dr. Jacob, uh, Dr. Thomas Vadakan, Dr. Rupesh, and Dr. Paulo Varghese. These are the 5 doctors.
sure.
So if you
I
can
got
just
it.
share that across. Yeah.
Yeah,
And
I
so
got it.
in the same image, I have also put in where I think around 5 of them whose degrees are missing. So if you can share me those also for the entire event throughout, I will have all the credentials and degrees ready. Only photographs will be replaced.
Yeah, right. Actually, I have called up two people right now, Dr.
Okay,
Ubesh and Dr. Jacob from Rajagiri. They will be sending their credentials in our WhatsApp group.
okay, sir.
They are in Corona, COVID duties and all the stuff. So possibly they will be sending it today itself, or I will make it sure for tomorrow at least.
Done, sir.
And Dr. Paolo and Dr. Anand will be called soon for their credentials. And Dr. Thomas is our moderator. He will be just sending it right now. And Dr. Lisha too. Okay.
Okay, sir.
Uh,
I think Dr. Lisha
I
has
think
already said.
then everything is complete, right? The speakers' credentials will be complete for our brochure, right?
So this will be these are the 5 people who have not sent anything. Now there
Yeah.
are 5 other people who have
Yeah.
not sent their credentials, as in they have not sent their degrees. Okay, so they have mentioned that they are the professor and the hospital name, but they have not mentioned that they are MD and
Okay,
what other
degrees.
degrees are there. Yeah. So all that has to be mentioned. So I think for that, Dr. Bino,
Okay.
Dr.
On the right way.
Krishish.
One second. I mean, let me get the names. Okay, 1 second. Yeah,
So I will WhatsApp you the image which has
yeah.
5 people who are boxed. The ones in the box have to give their entire credentials. The
Okay.
ones against which I have written degree, They need to
Okay.
send only their degrees. Rest I have received.
Okay.
Okay, I'm
Okay.
just
Okay.
sending you the WhatsApp. It'll make it more convenient.
Yeah, yeah. But still, can you just read out the names who have not sent the degrees?
Yeah,
Binu Simon, then?
Dr. Bino,
Yeah.
Dr. Vishish.
Vijish.
Yes, Vijish. Sorry,
Okay.
my bad.
Okay.
Vijish.
Okay.
Dr. Fatahuddin,
Okay.
Dr. Arjun,
Okay.
and Dr. Dilip Raman.
Dilip Raman. Okay.
Yeah.
Still, I think the WhatsApp group will be a good platform for you to inform them. Then
Okay.
by these names, so that they can they will reciprocate for sure.
Sure, sir. So I just
Yeah.
wanted your approval to send such an image with, all these things mentioned,
Yeah.
because
Yeah.
I thought it would be rude to ask them to,
Okay.
that you have missed this. Better,
That's
sir, if
okay.
it comes from your side. Okay, I
Yeah,
can put it,
that's okay.
then
You
I'll
are
be
free
fine.
to, yeah, no, I think Sudhir is also one of the admin. So you are free to get the degrees for your purpose. No, no issues.
All right,
Um,
sir.
you
No
shouldn't go
issues.
through me. You can
Done.
directly WhatsApp the mail to either in the guest lecture series or personally. No, no,
Okay,
no
sir.
problem. Okay.
So thank you so much. I'll do that.
Okay. Any other
Yeah.
help?
No, sir, I think that should be all.
Okay.
I'll send you the brochure once it's made
Okay. Okay. Thank you
for
very
correction.
much,
Yeah.
Ami and the CIPLA team. Okay. Thank you very much.
Yeah. Thank you, sir.
Okay.